Funding for this program was made possible in part by AARP, a nonprofit, nonpartisan membership organization leading social change and delivering value to people age 50 and over through advocacy, information, and service.
Support for this program is provided by the men and women of the Louisiana Forestry Association. Through sustainable forestry, LFA members promote the health and productivity of Louisiana's forests for generations to come. And the Foundation for Excellence in Louisiana Public Broadcasting.
Hello and welcome to Louisiana Public Square. I'm Beth Courtney.
And I'm Shauna Sanford, co-host of Louisiana, the state we're in. Well, when President Barack Obama signed the Budget Control Act into law in August, it was only the beginning of a multi-layered budget-cutting process. The bipartisan Super Committee, formed following the debt ceiling deal, is scheduled to present its cost-saving recommendations to Congress by Thanksgiving. The head of the Congressional Budget Office told the committee that without addressing spending on entitlement programs, it will be, quote, extremely difficult to put the budget on a sustainable path.
Well, Louisiana seniors, like the rest of those in the country, rely heavily on so-called entitlement programs, such as Medicare, Medicaid, and Social Security. According to AARP, low and middle-income seniors in Louisiana receive nearly 3/4 of their income from Social Security. As the deadline approaches for the Super Committee's report to Congress, there is debate over whether it will ever reach an agreement. But the door has been opened, and discussion continues on how to best rein in the rising cost of entitlement programs. And if cuts to entitlements do end up in the committee's recommendations, what will this mean for Louisiana's seniors?
On any given day, you're likely to find Jeanne George at the gym. At age 69, she counts on regular exercise to help keep her healthy. Something else Jeanne counts on is Medicare.
If Medicare benefits were cut, then for me, my version of the American dream would become like a nightmare.
The first in her family to graduate from college, Jeanne went on to earn her PhD. When it came time to retire, she had paid into Social Security and Medicare for 53 years.
I totally depend on Social Security to be able to retire. The whole time that I was working, I had the understanding that I basically had a contract with the government that I would be guaranteed a certain minimal level of income when I retired. And I based my planning for retirement, the income that I would be living on now, I based my planning on that guarantee being available.
Jeanne's story is like that of hundreds of thousands of seniors in the Bayou State. They're among the many who are keeping a close watch on the Congressional Super Committee as members grapple with cutting entitlement programs such as Social Security and Medicare. 6 Republicans and 6 Democrats make up the 12-member panel charged with trimming the deficit by more than $1.5 trillion in debt savings over a 10-year period. Early on, the group was criticized for the partisan logjam that has blocked progress in the past. Republicans were accused of not wanting to raise taxes, and Democrats of not wanting to cut too deeply into entitlements. Brenda Hatfield is the president of AARP Louisiana.
Everyone should be concerned. People should be concerned if they're younger. They should be concerned about their parents, about their grandparents, and their own futures, because this has an impact on their own futures.
AARP agrees that certain programs need to be improved, but Hatfield says outright cuts are not the answer.
We're really encouraging Congress to look at waste, look at government waste and spending, look at tax loopholes, investigate and look at abuse, look at fraud. Those are the main things that we're suggesting that Congress look at.
David Hood is the senior healthcare policy analyst for the government watchdog group, the Public Affairs Research Council of Louisiana.
I don't see any way it's going to be pretty. It's going to be bad. It's just a question of how bad. We really don't know yet.
According to AARP, 89% of Louisiana seniors, nearly 500,000, received Social Security in 2010. Their average annual payment was $12,600. 99% of Louisiana seniors, nearly 550,000, were enrolled in Medicare in 2009. And while Hood says seniors make up a small percentage of Medicaid recipients, the amounts they receive are large.
The elderly are definitely more vulnerable, mainly because they use a lot more services. Although the elderly is a fairly small portion of the Medicaid enrollment, like maybe 20% or something, the amount that they spend on their care is going to be much, much larger. A majority of Medicaid spending goes to the elderly and the disabled. So, I foresee their programs being cut.
And it isn't just the patients who will feel the impact. Louisiana doctors who receive lower pay for seeing Medicare patients will be paid even less as a result of the cuts.
If you're going to reduce what they get, they may not be able to afford to provide care in the program. Certainly there's nothing good to come out of this for providers, for recipients of care, for patients. It's all bad. It's just the extent to how bad it is that we don't yet know.
Back at the gym, Jeanne presses on, just like she has done her entire life, working out to keep physically fit on her end, all the while hoping the folks in Washington will work things out on their end.
People who depend on Medicare and Social Security are not looking for handouts. We're not expecting entitlements. I mean, we're people who've contributed to the system, who are high functioning and who want to continue to be high functioning, just and contribute in a different way than the way we contributed when we were working.
Welcome back to Louisiana Public Square. Tonight we're examining possible cuts to entitlement programs and the effect on Louisiana's seniors. In our studio audience tonight, we have Baton Rouge area residents, the majority of them beneficiaries of programs such as Medicare, Medicaid, and Social Security, who would be directly affected by any changes in benefits or services. Also joining us to explore this issue in depth is our panel of experts. Congressman Bill Cassidy is the Republican representative for Louisiana's 6th District. He is also a physician at the Earl K. Long Medical Center in Baton Rouge. David Certner, who is joining us from Washington, D.C. via satellite tonight, is the Legislative Counsel and Policy Director for AARP, the nation's largest organization representing the interests of Americans age 50 and older. Dr. Rani Whitfield is a board-certified family physician in private practice in Baton Rouge. He is also a national spokesperson for the American Heart Association and a member of the American Stroke Association's Advisory Committee. And Bruce Greenstein is the Secretary of Louisiana's Department of Health and Hospitals. His agency's annual budget represents roughly 1/3 of Louisiana's entire state operating finances, and the agency also supports areas including Medicaid and aging services. Thank you all so very much for being here tonight. I'm looking forward to a great conversation. Before we begin with our panelists, though, I want to go straight to the audience. In the very beginning of that piece that just aired, Jeanne said that if her Medicare benefits are cut, that her version of the American dream would become a nightmare. And I want to know from you all, does that resonate with you all? Do you feel the same way? Paul, I see you shaking your head.
Yes.
And tell us why.
Well, right now I have two insurances, mainly through the state and LSU. Medicare is my secondary, and Medicare has refused to pay a bill as small as $19. If I retire and Medicare becomes primary, I can't count on it because my medical bills are extremely high.
Mm-hmm. Yes. Charles, what about you?
Well, I think we live on a fixed income and we rely heavily on the Medicare benefits. And if they were to go or be seriously decreased, then that's going to affect our lifestyle. Even more importantly, I have a 92-year-old mother who basically could not survive without Medicare. She receives a very small amount of Social Security from her husband, the deceased husband. So it's going to have, I guess we are in the same boat with many people in terms of affecting our lifestyles.
Yes. Tom, what's your story? Does that resonate with you if your Medicare benefits are cut?
I can't imagine that anyone would cut the promises that were made to us. We put the money in and done everything right. I started with World War II and came back, used the GI Bill to get more education, went to work for a national company for almost 40 years. When I retired, my wife and I and our 2 children were healthy. Everything was wonderful. And then the damage came, and that's just something you can't plan on. But thankfully, we had the programs, and I can't imagine anyone touching the benefits that we have.
And Brenda, I'd like to get your response to that. You were in our piece. You're with AARP. You represent, 500,000 folks
Correct.
here in Louisiana alone. The organization represents millions across the country. This must be something that you're familiar hearing.
Yes, and it does concern me. And as I heard it referred to as entitlements, I'm sometimes insulted by the term entitlements as though they were handouts, because these are not handouts. We earned them through a lifetime of work, and we were promised Medicare and Social Security, and we are expecting to receive them as promised.
Yeah, and as a matter of fact, Jeanne said that at the end, we're not looking for handouts.
Yes.
Yeah, it does
Yes,
resonate.
it
Well,
does.
I'd like to bring in our panelists to get your take on what you're hearing. And Congressman Cassidy, I'd like to start with you because you're a physician and you're there in Congress and you hear what the folks here are saying, and I'm sure that you've heard others perhaps echo the same sentiment. What do you think when you hear this? These folks don't want their Medicare benefits cut.
First, I agree. It is a contract with the American people. It is something the contract should be lived up to. On the other hand, it's already being cut. Under the President's health care plan, it's estimated that the Medicare Advantage programs in Livingston Parish, for example, will be cut by about $1,800 per beneficiary in 2017. So there's already cuts taking effect. Now, this is the President's health care plan. Now, part of the problem is that entitlements is not supposed to be insulting, it is a technical term. If you look at the federal budget, by 2030, Medicaid, Social Security, and Medicare will consume the entirety of federal tax revenue. There'll be no money for defense, roads, research for Alzheimer's disease, for example. None of that will be there because those entitlements, and this is according to the Congressional Budget Office, will consume 100%. Now, I just read something today that GAO thinks that there's about $70 billion worth of waste per year in Medicare. $70 billion cannot fill that hole. We borrowed $1.5 trillion this past year. $70 billion is a lot, but nowhere close to $1.5 trillion.
So when you hear people make the argument about the waste, you think it's just such a small part that it's too insignificant?
It is so important to root that waste out. We've got to get the maximal value for every dollar we raise in taxes, but at the same time, it's not going to be adequate, and there's reasons for it. But by 2030, 100% of tax revenues will be going to Medicaid, Social Security, and Medicare if something different is not done. Medicare at that point won't be there for people. It just won't be.
David, I'd like to bring you into the conversation and get your take on what Congressman Cassidy has said.
Well, I think there is a big problem with health care costs in this country, but we shouldn't be blaming senior citizens. We know that health care costs in this country are running much higher than inflation, and they are causing problems all across the board, not just for programs like Medicare and Medicaid, but we're seeing problems at the state level, we're seeing problems for employers, we're seeing problems with individuals. Health care costs are too high in this country. And it's not as if seniors aren't paying a lot out of their pockets for health care already. In fact, the typical senior spends nearly 20% of their entire income on health care. So we need to get at the root problem of high health care costs, but not simply say to seniors, we need to cut your benefits and you need to pay more. We need to bring the cost of health care down.
And Congressman Cassidy, as you were saying, you were not blaming seniors.
Of course not blaming seniors. And of course I agree we have to bring the cost of health care down. But even if you lower its rate of inflation by 1 or 2%, which is a lot, you still, by 2030 or 2035, have 100% of our federal tax dollars going to 3 entitlement programs. That is not sustainable.
But what is Congress doing about it?
Well, one of the reasons that there is this bipartisan effort to decrease the deficit is precisely to preserve Medicare for those who are on it now and strengthen it and preserve it for those who will be. The Republican proposal, for example, will not change Medicare from what folks have known in the past if you are 55 and above. If you're 54 and below, it will actually strengthen it to the degree, and it will change the program, but it will strengthen it in a way that it will still be there. And that actually has been shown and scored to actually preserve the program.
And just in case folks were not able to hear your question, it was, what is Congress doing about it? Dr. Whitfield, I want to bring you into this conversation because you deal with many patients who are on Medicare and on Medicaid. Can they take the cuts? I mean, Congressman Cassidy says we have to have cuts.
I think there will have to be cuts, but I never thought in my wildest dreams that I would actually have to compromise patient care to consider reimbursement. In other words, do I accept the patient, or do I not accept the patient because I won't be reimbursed, or my reimbursement is so low that I would have to close my practice?
Is that going to affect this generation, you know, like the people in this audience here, you know?
It will have a direct
like
effect on you guys
citizens,
in January.
You know, it's going to affect people in the other generations behind us, our future, our posterity.
Most definitely. It's going to have an impact on you guys in January and in the future generations to come. And so what I see in my practice in the individuals just like you, just last year, I started to get the questions about, hey, doc, are you going to be able to take me next year? I was like, wow. So individuals like yourself were already familiar with this, the SGR, the sustained growth rate. And so they were asking questions already about would I be able to take them as patients. In Louisiana, we are a health professional shortage area. So we already have a lack of physicians to care for patients as it is. So if these cuts happen, and I don't know the answer, Dr. Cassidy and I have worked together with patients that are okay long, but I don't have the answer. We both know about poor indigent patients and how we have to treat them, but we don't have the answers. But if these cuts do happen, I may have to either close my doors and not take patients at all that have Medicare, or shut my practice down altogether. The government wants us to have electronic health records. You know, that system that I just implemented in my practice cost me $25,000. There are some incentives that we're supposed to get, but those incentives may be cut because of the cuts that are up and coming. So there are a lot of issues, and a lot of family doctors, a lot of doctors, period, are having issues with this, and the cuts will have an impact on our society.
So it's a very, very real problem that doctors could eventually turn patients away. Bruce, at the state level, how large is the Medicaid system here? How many people are enrolled in Medicaid here?
We have about 1.2 million people enrolled today on Medicaid, and we insure about 29% of the entire state as we speak.
And the budget is what?
The budget is about $8 billion for the state and the whole department. Last year we spent $6.7 billion on Medicaid alone. And
the shortfall, where are we with the shortfall?
Our shortfall is addressed. We're running a balanced budget today. So we're looking at this fiscal year. We're making ends meet, and we'll be able to carry out, as the budget stands today, all of our requirements for the rest of the year.
Well, David mentioned something about problems at the state level. Talk about the problems at the state level and your concerns about the recommendations that could come from the Super Committee.
Yeah, so I have a lot of concerns about what the future looks like. Tom raised a great point. He fought for our country, comes back, goes to college, has a great life, and he has expectations from our government programs like the ones that were promised to him. That's not at all what we're trying to get at, but it makes the decisions so complicated for people like Dr. Cassidy. Our country hasn't got into the financial trouble overnight, and we're not going to be able to address the complications overnight. But if we don't do something now, we're going to have grave problems down the road. It doesn't take very much to see what's happening in Greece and potentially Italy as what happens if a government doesn't address its long-term sustainability. With regard to what I see that could be compromising that Congress would turn out is across the board. First of all, my concern is that Congress doesn't get their act together and make a decision, and these automatic cuts occur, and we'll see our defense programs compromised dramatically. This is too uncertain a world for me to feel comfortable having our defense cut back without a plan. The second piece is, because it's so difficult for groups to agree upon having cuts in their programs, whether it's in Social Security or in Medicaid or Medicare, we can't seem to get compromise, and that's originally why we went to the idea of a super committee. But thirdly, we're coming close to the deadline for the super committee. Healthcare is such a complicated issue and always divisive in our country. Just watch the debate, national debate around Obamacare for that. I'm concerned that the cuts won't be well thought through. And as an example, for the Medicaid program, if the cuts that Congress makes in Medicaid are simply just to reduce what it pays the states, that means we'll get less money here to carry out our programs, and my suspicion is, or my fear that is, that we don't get more flexibility as a way to carry out those programs. So we're already have the program at its max.
Well, and I know that you're an advocate for states having that flexibility, which we'll get into a little bit later on. But Dale, I'd like to bring you in on this conversation because I know you have a lot of concerns.
I think the concern that most people have, not only excuse me, because of Medicare and Medicaid, but the general cost problems that we have in healthcare in America today. I think one of the undertones we are constantly hearing is that the private sector can do a better job. Congressman Cassidy mentioned there's going to be a cut in the Medicare Advantage programs. That was originally put in to demonstrate that the private sector could do it cheaper than the federal government. The fact of the matter is the Medicare Advantage providers have been paid substantially more than traditional Medicare. So the attempts to move the Medicare population to the private sector have not been successful. They've been very popular because the additional benefits that Medicare recipients receive through Advantage programs, but they have been extremely expensive.
So David, I'd like to get your take on that. What Dale just mentioned, this whole issue of moving to the private sector.
Well, I think we have to look at what the facts are here, which is that growth in Medicare costs is actually less than growth in costs in the private sector right now. And so the problem is just not a Medicare problem. The problem, again, is a healthcare cost problem. And part of the concern we have, and was just expressed at the state level, is a lot of the debate going on in Washington right now is not really about how do we lower these healthcare costs, but a lot of the debate in Washington is how do we shift our costs to somebody else? So how do we make the states pick up more costs? How do we make employers pick up more costs? And of course, really from our particular concern, how do we make senior citizens pick up more costs? And we don't think that's really the way to deal with the problems in the healthcare system, is just to shift the cost to somebody else. We need to go in and change the way we deliver healthcare so we can actually lower healthcare costs. It's not just about waste and fraud, which is very important, but it's about doing more to change the way we deliver healthcare so we can make it more efficient and more cost effective than we have today.
David, is it realistic to think that there won't be any cuts? I know that in an ideal world you would like to see no cuts, but based on the comments by Congressman Cassidy and based on the comments by Dr. Whitfield and also Bruce here, I mean, the cuts are inevitable, right?
Well, I think we first need to distinguish between cuts to benefits and services and efforts to save money in Medicare. And we think there are lots of ways to save money in Medicare. We talked about fraud and abuse. We certainly can do more there. We can do more to attack high drug costs. We can do a better job of care coordination. So there are lots of things we can do to first lower the cost of health care. If we find that all those things still don't get to where we are, then sure, we can talk about more drastic measures. But we haven't even begun to tackle these other problems of health care cost containment yet before we simply get to cost shifting.
Tom, you weren't shaking your head there. Tell us what you're thinking about what David said and reducing healthcare costs.
A couple things. Dale mentioned Advantage plans. As I remember it, when they first were proposed or enacted, they were to save Medicare 5%. In other words, they could do it 5% cheaper. I think I've recently read they're costing 14% more now because they've added things in, so forth. So to me, that means that should be, over time, closed down, bring those people back into Medicare. If we can do it cheaper, why are we paying somebody to 14% more? That's the first thing. The second thing is, I can't remember back how long Congress has been dealing with this problem, and yet they haven't done anything to do it. Even now they're talking about whatever the Committee of 12 come up with, yes, that it might be backloaded, where it wouldn't start till 2013 or something like that. We need to start now.
Now, Tom, can I address some of that? I'm hearing two different things. If we cut back on Medicare Advantage, that means that more people, frankly, will begin to buy Medigap policies. AARP has a fair $700 million a year they earn off of endorsing such programs. As we do that, it's going to be more money out of the senior citizen's pocket. It really is. So if we begin now, as you say, Tom, then actually what you're really saying is we want seniors to begin paying more now. The reason the Super Committee is attempting to backload a little bit is because it realizes people, particularly seniors, need time to adjust. And so you rather give people, if there are any changes at all, time to adjust. Right off the bat, it's going to be difficult for folks on fixed incomes to do so. So I kind of endorse the fact that we're going to ease into this. We need to give people time to prepare. At the same time, keep in mind, every 13 seconds, a baby boomer gets onto Medicare. Every 13 seconds. We can change the cost curve on Medicare and healthcare expenditures, but people that look at this seriously say that as long as we have so many baby boomers entering Medicare age, we've got to do something significant to save the program. To save the program. Now, the second thing about that is, the reason everybody says, wait a second, I've been paying into the system, most people have more brothers and sisters than they do children. And the whole problem with Medicare is that it is pay as you go. The younger people pay for the older. As it turns out, as families have gotten smaller, there's fewer people paying for those who are ahead. So we certainly need to control healthcare costs. Totally agree with David, but if you look at the issue, as CBO does and others, the fact that every 13 seconds a baby boomer goes onto Medicare is a cost driver that cannot be corrected only by waste, fraud, and abuse, or even by decreasing the cost of health care.
Bruce, how do we do that?
How do we fix health
yes.
care problem?
How do we bring down those costs?
Oh, if it were so simple,
yeah.
Surely it would be done again. The health care problem, you have to look at it from a couple different ways. If it was so easy to save money, we would be doing it. But the problem is, we're providing more healthcare services than we can pay for today. When we save money in healthcare, it means that somebody is not getting the income that they thought. Whether you're running an imaging center or you invested in a hospital, if we can reduce the amount of times that people go in an emergency department, someone's going to lose revenue. He put in electronic medical records so he doesn't have to do maybe 2 different MRIs because he has access to the first ones right there. That means the guy who's running the MRI facility is going to miss out on another patient. We have to understand that there's going to be some pain along the way, that incomes are going to shrink a little bit. There's going to be, at some point, not as many people will be able to get all the services that they had before. I'll just give you an example from our program, because we don't have the luxury that Congress has had to spend way more than they take in. We balance our budget every year. So we've made adjustments. Sometimes we cut back rates. Sometimes we've been going after fraud and abuse very hard to save money. We've done comprehensive, what we call sort of a disease management for people with chronic diseases to make sure they get appropriate care, that they get some wellness and prevention, and we avoid some hospitalizations. Early next year, we're moving to our version of managed care, which is going to cost quite a bit less, guaranteed up front, than the traditional Medicaid program. And that emphasizes, again, wellness and prevention, managing chronic disease, do a better job for prenatal care so we can avoid complicated births, and we'll save money in the long run in our own program.
But whatever the decision is, whether we get recommendations by the Super Committee or if Congress has to step in or if nothing is done and those triggers are released in January, those will affect what you have in place right now, or what you plan to have in place?
We don't have a line of sight what the triggers look like in terms of the impact on Medicaid. But if there's going to be fewer dollars coming in to match our state dollars, then without question it'll have an impact. There's no way to cut millions and millions of dollars out of the program without having an impact on the way we run our programs. What we do here in Baton Rouge is we figure out the way to have the least amount of human impact. We've been belt tightening at the department for quite some time. When I got here, there were about 10,000 employees at DHH, and by the end of this fiscal year, we'll have about 8,300. So we've reduced the cost of running our government programs dramatically. We've made the management component more robust so we can manage healthcare as we go through, and we've done quite a bit of fraud and abuse.
So, Dr. Whitfield, when you hear them talk about reducing healthcare costs, help us to understand, why is it so expensive?
Again, fraud and abuse is a big issue. But my concern, and I got to go back to I'm looking at you guys as my patients today. As a family doctor, we look at things as the patient-centered medical home. When you guys come in my office, we have relationships. I know about graduations. I know your family members. If these cuts go into place, some of you guys are going to lose your primary care physicians. Some of you all won't be able to see any more primary care physicians because they won't accept you. I already have problems referring to some of the colleagues, my neurologists or specialists, because they're saying, I'm not going to get reimbursed enough to see these guys, so we're just not going to take them. So for me, this is bigger than just, and these guys know the X's and O's, but I'm talking real day-to-day medicine. I know names, faces, and people that I love and care about. I'm going to lose patients. I have families that I feed. When I talk about my nurses, my staff in the office, we're going to lose a lot of those people because, I can't afford to pay them.
And then the question is, what happens to those patients? Where do they go? What happens to them?
What happens? I mean, again, we're in a health professionals shortage area. For 17 physicians to treat 1,000 patients, that's just too much. You can't provide high-quality health care to these individuals. It's actually very disheartening and scary. And I'll tell you, I've spoken to colleagues. I'm not going to be the guy that's going to initially say I'm going to stop seeing Medicare patients, but I have to consider those things. I really have to consider those things when it comes to the cuts. So something has to be done.
Yes, Dale.
Is that a realistic scenario, given the fact that between Medicare and Medicaid alone, that's over half your patient population?
I have 35% Medicare.
How many physicians are going to walk away from 50% of their practice? They might take a hit with this, but I can't see that most people will walk away from half of their business.
Studies already show that because Medicare pays below cost for some primary care physicians, that seniors are having a more difficult time finding a primary care physician. Now that's not anecdotal.
I agree.
There are studies. And as it turns out, Medicare already has a plan to effectively not update for inflation what physicians are being paid, so much so that it's estimated, I think maybe 10 years, that Medicare will be paying less than Medicaid. Now, at Earl K. Long, I see lots of Medicaid patients, which begs the question, why does somebody who theoretically has insurance come to a hospital for the uninsured? And that's because Medicaid pays below a physician's cost. And if he or she sees too many Medicaid patients, they can't pay their nurses, they can't pay their overhead. So already, Dale, we are seeing seniors having a difficult time finding primary care because of Medicare reimbursement.
I agree with you, but I understand the problem being that the proceduralists are being compensated quite well, where the primary care physicians are not. Why have we not been able to move those monies from the proceduralist to the primary care? I agree with the doctor totally on that.
And Mr. Banks, there are proposals in to do that. That's one of the things that the AARP has done, American Academy of Family Physicians. They want to get a 3% increase, freeze funding for a certain amount of time. Is that going to happen? I don't know, because we're not trying to pit specialists against the primary care doctors, but for years we felt like we've been underpaid and overworked, kind of like the school teachers. I talk to my teachers. You're underweight and overworked because we were the gatekeepers initially of healthcare, but healthcare, the whole system is changing. But is it realistic? It is very realistic, because my overhead and my cost in my office, either I'm going to stop taking Medicare patients and just keep the ones that I have, or there's a great possibility. 35% of my practice is Medicare. And that's about $20,000 to $25,000 a year that I could be impacted by, if not more than that. So for some physicians, it's a very real thing. When you got buddies of mine say, "Hey, I'm going to go sell Amway or do some other things," and there's new models out there now. Doctors are now charging patients a flat fee at the beginning of the year, $1,500, $2,000. They have to maintain some insurance, and then they'll see them. But they're limiting their numbers of patients, and so they're not actually serving the community. And I'm a primary care doctor that's about serving the community. So for me, just to take an initial amount of money and have a group of 600 very healthy patients that only see me one time a year is not serving the community of Baton Rouge or Louisiana.
To add a little levity, maybe we can take the hover round money that we're spending and send it to you.
Hey, that help me out.
David, I'd like to bring you in on this conversation too and get your take on the things that you've heard here about the very real possibility that, you know, some patients are going to end up without primary care physicians. And it really is a very difficult thing, as you expressed earlier, to get these healthcare costs down.
Well, and we did just raise a real problem about reimbursement under the Medicare program for physicians. If we don't take action by the end of this year, we'll see, again, large cuts approaching almost 30%. We obviously can't have that. We've been delaying this in the past, but we really do need to change the way we compensate physicians. One of the things we do now under the current system is we simply compensate people for all the tests they run and all the services they provide. There's not really a very good incentive there to provide value to the patient. We really should try to move our system of how we compensate to one that doesn't just compensate on the volume of the services, but on the value you're providing your patient. And if we can put different incentives into the payment system, I think we'd have a better payment system, and we could put better incentives in to both compensate people who are doing basically the right thing, and we want to compensate them with the right amount, so we make sure that people do have access to a doctor.
Eileen, I'd love for you to chime in here with your thoughts, because I know you're very, very concerned about how you'll pay for these services if, in fact, your benefits are cut.
As a retired person and on a fixed income, if Medicare costs are cut, and you're saying that this is something that is going to happen, how, in fact, will we be able to pay for Medicare benefits? Give me some suggestions.
Well, first, it isn't clear what kind of cuts will occur. Under the Super Committee's charge, they cannot increase the cost to an individual patient. So under the current, since we're talking about the Super Committee, under their current rules, you will not be able, you're not going to pay a higher premium, for example. Okay, that's number one. Secondly, under the Republican proposal, not to be partisan, but just to say that if you're 55 and above, the program basically stays as it has been for you. What I went back earlier responding to Tom, you've got to give people a chance to adapt if you're going to make a significant change.
I heard you say that.
And so the idea being, listen, I'm 54. I have 10 years to begin to plan for this process, if you will. And so, but if you're already on it, nothing changes from the program that you have known. That said, under the President's health care plan that was passed, costs will continue to rise for the people who are currently on Medicare. And that's under the plan that was passed, President Obama's plan 2 years ago. So partly there is going to be a certain amount of cost sharing. Again, as people move from Medicare Advantage and have to buy more richer Medigap policies, that will be more money out of your pocket. And that's just part of it.
And I guess that's pretty much what it comes down to. It will be more money out of your pocket. Yeah, it will. Yes.
That's what I see.
Yes. Yes, Tom.
I've been going to the same family physician for 35 years. And it's amazing how his visits have changed. He now comes in with a little laptop and he can pull up all the information that has taken place with me or my wife and so forth, and he can schedule the stuff. He can notify the other physicians that he's sending me by email, I guess it is, or wire. 4 or 5 sheets of paper go over to whoever they want to send it to that tells everything you'd want to know about Tom O'Brien.
Right, right.
And so forth. So I think it's wonderful, the progress they've made.
And of course, as Dr. Whitfield can probably attest, that costs.
Yeah, it costs, Tom, but those things are great.
But then they save at the other end.
Right. We reduce errors. If you move to another city, we can get those health records to another doctor. If you're in an emergency situation, I'm at home in my bed watching television, I can click on the mouse and pull your records up. So those things are great, but they do cost. And that's the issue, Sean. I mean, you know, we want to have an updated office so you guys can come in and be treated more efficiently, quicker, you know, with better medications. We eliminate errors. There's certain medicines that have the similar names. You don't want to put Celebrex in place of Celexa. So these things are really, really good, but they do cost us money. And
yes.
If I could just say, I mean, that's a great example of how it's working in one individual office. But you hit on one of really the future of our healthcare system, and it becomes the opportunity for better health care. You see reduced medical errors. We know your whole history. We're able to go ahead and forward your information to say if you're going to be referred to a specialist or to a hospital, all that information travels with you. Estimates are between 5 and 10% of total health care costs can be saved by eliminating the duplication. So you don't get, you don't have, say, labs and imaging done in one place and they have to do them again because they don't have them. But that rapid increase in technology, which helps you, there's also a rapid increase in technology for things like whether it's new procedures that could be done for the heart or new medicated stents or very expensive pharmaceuticals. All those cost as well, and they keep us all alive, which is great, but they cost the whole healthcare system more and more every year. So United States, while we might have the most expensive healthcare system on the planet, we're still the source of great innovation and the highest quality healthcare in the world. That has a cost for us for sure. We want to make sure as many people have access to it as possible. But if we don't give Congress the support, and hopefully they go ahead and follow through, to be able to come up with policies that allow the greatness of our healthcare system to be sustainable, in 20 years we'll be just like any other country without all the innovation.
Yes, your question.
I'd like to just say, right now we use about $1 out of every $6 in the entire economy goes to health care. That's far more than any other nation. And we do have great health care in this country, but quite frankly, the outcomes for the money we pay are no better than most of the other nations in the world that are spending far less on health care. So there's a lot we can do to reduce the health care costs while still maintaining the quality of health care. And that's a key challenge for this country, not just for the Medicare and Medicaid programs, but all across the board. Because the debate in Congress right now, in the Super Committee, is really about cost shifting. It's about telling people to pay more. And it's about telling seniors now to pay more, not in the future. They have a budget target they're trying to meet now, so they're asking seniors to pay more now. Well, this doesn't get at the issue of holding down health care costs, and I think that's the key debate we need to get back to.
Okay, and bringing it back to the audience, you have a question for Congressman Cassidy.
I'm a veteran. Okay.
Thank you for your service.
I'm a veteran from the Vietnam era, and I was just wondering, in the healthcare debate, veterans are going to be affected. We have, about 45,000 troops coming home from Iraq, and we're drawing down from Afghanistan. According to the news, President Barack Obama is doing that. And I was just wondering, in the debate in Congress between the Democrats, Republicans, and Independents, are y'all doing any cuts in military medical spending for
veterans? Veterans.
So, first, again, thank you for your service.
Yes, sir.
We are all indebted to you. Secondly, there is support on both sides of the aisle for veterans. And so there's going to be a continued commitment. But remember what Secretary Greenstein said at the outset. If the budget Super Committee is unable to come to an agreement, there will be a kind of across-the-board cut. And there'll be about $400 billion cut, I think I have that right, from Department of Defense. Department of Defense has, among their biggest ticket items, if you will, are programs like TRICARE, which is the program, the healthcare program for retirees from the military. They are going to begin, as I understand it, not because Congress asked them to, but because this is a way for them to mitigate, if you will, to lessen the impact of these huge cuts they're taking, to increase monthly premiums for TRICARE beneficiaries. Now, I don't remember chapter and verse on that, but it's going to be $5 to $10 a month, I think. So there will be some increased cost sharing for TRICARE beneficiaries. Now, still, it's going to be very much smaller than the typical private insurance program, if you will. But it is my understanding that there will be some increased cost sharing, again, driven not by Congress directly, but by Department of Defense.
Well, we are quickly coming up on the end of the show, but Bruce, I want to give you an opportunity to get in here. We cannot let the night get away without hearing your question.
Okay, I too am a veteran, Vietnam veteran. I served, I worked before I served, and then after I served, I put into the system. Like she was saying, that thinking, okay, this is not an entitlement, this is a contract. We were taxed. I was taxed for 40 years. I worked hard for every dollar I got. And I do hear these things about baby boomers. I am right in the middle, baby boomer. But I don't hear anything about illegal aliens costing us hundreds of billions of dollars off the system, and nobody seems to want to do anything about it. They always point the finger at the people that it's not my fault that this thing is going broke. It's not our fault.
When the program was designed, it was designed in 1965 as a pay-as-you-go program. And so about that time, folks had about 4 children on average per family. Now it's about 2.2 or 2.1. About the same time they invented the Medicare program, the birth control pill was invented, and family sizes began to shrink. And so no one's blaming anybody. Believe me, I'm a baby boomer too. It's just a question of when you design a pay-as-you-go program, assuming that everyone will continue to have on average 4 children, and as it turns out the size of families has decreased significantly, then the original model no longer works.
I understand that, but still does not address the problem of the illegal aliens.
So the illegal aliens, they do not qualify for Social Security. Now, they do go to emergency rooms, and there is a certain amount of cost shifting from private insurance companies to cover the cost. And as Bruce will tell you, there's some money that comes from the federal government to care for the uninsured and non-Medicaid patient. That said, and I'm not saying that the illegal alien issue is not a significant problem. In fairness to the president, he's deporting a lot of illegal aliens. In fairness to both parties, there's a real intense interest in how we deal with the issue. But the Medicare issue is probably not to be laid at their feet.
I would agree 100% with the Congressman. In order to get Social Security and Medicare, you have to have paid into the system, contributed to the system, and earned it. And if you are an illegal, you are simply not part of the system. Not part of the Social Security and Medicare system anyway.
Yes, thank you for that. You raised an important issue just a few moments ago when you mentioned that here in the United States we're paying more for health care, but we're not really getting the biggest bang for the buck. And I don't know if you all take issue with that or if you agree with him with that. I know Congressman Cassidy, not long ago, you made the statement that folks who are on Medicare often have worse outcomes than those who are uninsured. Medicaid are come out worse than those who are uninsured.
Well, that was an observation I made based on a study by the University of Virginia. And there's different explanations for that, but that data stands out there, and there's other data that supports that patients who are on Medicaid sometimes have worse complications than even those who are uninsured. It may be because they have more procedures, and some of those procedures are not necessary. Mm-hmm. That's a possible explanation for that data.
What about his assertion that we're paying more for health care, but we're not necessarily getting better health care?
I don't think anyone argues with that assertion. But what one person's waste is another person's valuable service. In England, they will not necessarily do a hip replacement if that person is over, say, a certain weight. If they're too obese, they don't get a hip replacement. In our country, we say, wait a second, we're frankly going to give you the hip replacement. There's other services that elderly in our communities get routinely that in other countries may not get. So part of that is, if you will, driven by the fact that we have a high level of service for folks, higher level than others. But that said, of course we could wring some of that out.
Yeah, agree, disagree?
Yeah, I mean, I agree.
Let me add to that too, because it's not just comparing overseas, and there's obviously different cultural pieces in effect. But even if you look within our own country, there are parts of our country where we spend twice as much per patient on Medicare as we do in other parts of the country. And when we look at the outcomes for those patients, they're no different. So we're obviously spending a lot of money that's unnecessary care, wasted care, and in some cases that extra care can actually be harmful. So we really need to do a better job of looking at the evidence and what care is right, because we want to get people the right care at the right time, not just throw a lot of care at people, which wastes a lot of money in the system.
Okay, Congressman Cassidy.
Louisiana gets a bad rap because I think David's referring to what is called the Dartmouth data. And in the Dartmouth data, it shows that Louisiana spends more per Medicare recipient than, say, they do in a state like Minnesota. As it turns out, though, and Bruce can attest to this, we get a lot less Medicaid dollars per beneficiary than those states do. And so some of our problem, I have patients who get a liver transplant when they turn 65. I would have liked to have gotten it for them when they were 62. I've had to nurse them through, if you will, doctor them through, because they didn't have coverage. So there is pent-up demand. So partly, there's a part of this which says, wait a second, if we have a problem of the uninsured, which we do, and it's disproportionate in Louisiana relative to other states, that there's a pent-up demand when they get to Medicare, and that skews that statistics a little bit. Technically saying you can't use Medicare spending as a proxy for overall spending.
Bruce.
Sometimes I think we get too hung up and start to miss what health means. We don't really want to pay for more health care. What we want is health. And so we know if you're on any health care program, if it's Medicare, Medicaid, private health insurance, we have some responsibilities ourselves, and we should constantly remind us as consumers of healthcare services or as parents of kids that want to stay healthy, we know we own our own health. We're responsible to do preventive and wellness exercises. We should be, if we get a prescription, make sure we fill it and are adherent to that prescription. If we have chronic disease, we know we need to do a lot to control it. If and today, using the Louisiana example, we have an incredibly high degree of children with diabetes, type 2 diabetes. We have among the highest rates in the nation of obesity in children, and we're not doing enough to exercise control over our fitness, our eating, and our exercise as a way to try to bring health to us and our families rather than just worry about the healthcare system itself. So we need to make sure we share some of the focus. We're all very passionate about making sure we have access to good quality health care, but we should all remind ourselves we're part of families and congregations and communities that we should focus also on wellness and the health of our communities as well.
We are about to wrap up, but before we go, I've got to get your take on the Super Committee and how you all are feeling about this committee's ability to really tackle and deal with the problem that is at hand. And Dr. Whitfield, I'll start with you.
Shauna, I'm a little nervous. We have a very short window of time. By January 1, something's going to happen. I don't see how 1.5 trillion or 1.2 to 1.5 trillion dollars in cuts, something's going to happen in that short window of time. So I'm a little bit nervous. I've had to reevaluate my practice and what I'm going to do. My confidence in them is not very strong. If you look at statistically, Congress does not look very good right now. Sorry about that, Cassidy. But the country does not have a favorable opinion of Congress right now, and I'm not very confident. And I do see, unfortunately, that some cuts were going to happen, and I'm going to have to reevaluate my practice.
David, your take on the Super Committee?
Well, I'm nervous about the Super Committee because this is not a how do we fix healthcare Super Committee. This is how do we reach a budget target Super Committee. And so they're focused a lot more on the numbers than they are the policy and the health outcomes that are necessary. And because they're focused on reaching numbers now, they're also looking at making changes to people now. So when they're looking at Medicare, they're not looking at changes 10, 20 years down the road. They're looking at changes that will affect Medicare recipients right now. So that makes me nervous because they're not really looking at healthcare costs. They're looking at seeing who can pay more so the federal government pays less.
Secretary Greenstein.
Yeah, I'll just give it to you in one line. Cost shifting does not equal cost savings. I'm very concerned. We have the country's most complex social problem, which is health care. It's not going to happen in just a couple weeks, especially with the holidays in between. So the focus instead is going to be how to shift costs to whether it's families and businesses, seniors and states, as a way for Congress to make up their number, and that I'm afraid they'll do it on our backs.
And Congressman Cassidy, you get the last word on this.
I think the Super Committee, first, two aspects to that question. The Super Committee will achieve at least part of its goal, if not all of it. There may be some sequestration on top, but it will be, but they will achieve at least part of their goal. I think they will. Secondly, as regards health care, I totally agree with Bruce. And by the way, every person in this room has a story to tell about health care. And so I think the fact that we know we've got to do some reform to preserve Medicare for seniors, to strengthen it and preserve it for those who will retire in the future, is the responsibility of the American people to step forward, engage in this conversation, and come up with a solution that is a health care solution, not a budget solution primarily.
Well, this has definitely been a great conversation. Thank you all so very much. That's all the time we have for our Q&A. We want to thank all of our panelists tonight: Congressman Bill Cassidy, Dr. Rani Whitfield, Secretary Bruce Greenstein, and David Certner, who is with AARP, joining us from Washington, D.C. When we come back, we'll have a few closing comments, so stay with us.
Well, that's all the time we have for this edition of Louisiana Public Square. We encourage you to visit our website at lpb.org/public square and take this month's survey. While you're there, you can sign up to follow us on Facebook and Twitter and volunteer to be on the show like audience member Paul LaRock did. You can also comment on tonight's show like several viewers did following last month's Shreveport remote covering Louisiana's dropout problem. S. Lee wrote, "I believe the dropout rate can be drastically cut if more parents are involved in their children's education." And Tommy writes, "Stop giving our tax dollars away on all of these free programs, and the people will see that they need an education to survive in this world." Well, that's true. Well, thanks, everyone, for your comments, and we appreciate your feedback.
Well, as the bowl games gear up in December, Louisiana Public Square explores college athletics in the state. What oversight do student athletes get? Should they be paid? Do sports programs pull money away from academics or attract alumni support? We'll explore these issues and more next month on Athletics versus Academics, College Sports in Louisiana. Thanks for watching and have a good night. You guys give yourselves a round of applause. You did an awesome job.
Good night, everyone.
Funding for this program was made possible in part by AARP, a nonprofit, nonpartisan membership organization leading social change and delivering value to people age 50 and over through advocacy, information, and service.
For a copy of this program, call 1-800-973-7246 or go online to www.lpb.org. Support for this program is provided by the men and women of the Louisiana Forestry Association. Through sustainable forestry, LFA members promote the health and productivity of Louisiana's forests for generations to come. And the Foundation for Excellence in Louisiana Public Broadcasting.